So there are enough scientific data, but I would say the scientific data is also as good as the number of attendees here post-lunch for the session regarding rehabilitation in critical care, right? So I searched a lot, and I'll just present the important ones that have come across. But to begin with, my acknowledgements to Dr. Devanganu who helped me prepare this presentation. Ms. Nasreen is our patient, Mr. Akash is our patient who has consented with their photographs and videos for this presentation. So, as I always say, a case will set the pace. So, for preparing the presentation, I was thinking, what is the scope of PMR in ICU? Right, so which system actually am I talking about? So to begin, I just thought of a case. She's a 16-year-old female and she's admitted with history of generalized weakness. She's found quadriparetic on admission with a single breath count of less than 10. Our arterial blood gases shows retention of PCO2. Neurologically, the reflexes were absent. Are there PGTs in the room? And would somebody like to volunteer? What am I talking about? And this is a session on PMR, so no rocket science, no prizes for guessing that we are talking about a Guillain-Barré syndrome, right? And she is intubated and ventilated. There is evidence of alveolar cytological dissociation in the CSF and started on IVIG. So the intensivist job done, right? So yes, while we are doing the intricacies of a management in terms of clinical management, right? So what about the dose of IVIG? What about the power, the improvement in power in daily basis? And when to wean her off of the ventilator. So those are the clinical intricacies that we are doing on her. What our PMR colleagues are doing simultaneously is what I'll show you. So what system is being affected by immobility? I asked me. So to understand the scope of PMR, so I was thinking, what system does immobility involve? And it was not a surprise for me that it involves almost every system. For brain, it will manifest with delirium, neuroplasticity. There will be emotional trauma in ICU. In the cardiology part, there can be DVT, orthostatic hypotension, edema setting up of the immobility. Good afternoon, sir. I've already begun, sir. Okay. For the lung, that will cause a basal atelectasis, right? Persistent ventilator dependence, right? And of course, the oxygenation. For renal, because prolonged immobility may mobilize calcium from your bones and it can actually precipitate calculi. There are chances of recurrent UTI, particularly in the elderly in terms of immobility, right? For GI, there can be ileus, constipation. This is a very common, I'm not talking about rocket science. You imagine of an immobile patient in ICU for 4-5 days and you can see everything happening in front of your eyes. For skin, yes, precious ulcers. Our nurses are terrified. We are also terrified. Right? And of course, very emotionally traumatic to the patient family members who, seeing a skin breach and anticipating the pain involved in it. Musculoskeletal, yes, overwhelming because there are so much evidences of critical care neuropathy, critical care myopathy, what is now combiningly called as critical care neuromyopathy, and it actually sets in within 48 hours of immobility and within 48 hours of ventilator involvement. And of course, in the long term, there is persistent weakness and decrease in the quality of life. So the PMR, just like an intensivist, basically owns every system, I would say, right? So I am not talking about a system when I'm talking about a PMR, right? It probably involves every system. So there are techniques particularly for every system that needs to be improvised upon. So that is how holistic, right, a PMR should be in ICU. So this is what we know probably, right? At the core, it is neutral to age, gender or duration of the illness. It starts as soon as the primary disease is a bit addressed with, right? It starts, I would say, simultaneous with the clinical management. And of course, the aim is to optimize functioning and reduce disability. And it can involve a various spectrum of therapies related to speech and swallow, cognition, respiratory, physical, recreatory, I would say, and of course, even the occupational to begin with. yes, we are aware of the post-ICU syndrome, which is characterized by new or worsening impairments in any or one of the domains of cognitive function, psychological function, or physical function. And of course, it encompasses care beyond the walls of critical care. Early mobilization is mandatory to prevent the PICS. But then, what are the obstacles? So, why are we know about this? So, what are we talking about today? So, what are the obstacles in our way? You see, it starts, this is a cartoon, is this, when you touch your feet 20 times, no, my cap will fall off, right? So, it starts with so simple things. There are some findings, right? Obstacles to early access to rehabilitation. In America, they say lack of physicians' orders in 90% cases, and in 10% there was lack of logistics. Here might be just the vice versa, right? But, but I am hopeful, because in 2014, there was a study published in IGCCM, Indian Journal of Critical Care Medicine, where 86%, there are 659 responders, and 86% had a bedside mobilization, even 70% to wheelchair and 67% to some walking. The numbers are quite better in 2021 findings, again published in the Indian Journal of Critical Care Medicine. So just let me tell you what we did for the patient, what we usually do in our ICUs. I work in a tertiary care hospital with 90-bedded ICU, around 60% undergo physiotherapy twice daily. Average time is 10 to 20 minutes, depending on the availability of the therapist. I'll come to that. And you see, this is the journey. Just a short clipping. I couldn't take the photo when she was quadriparetic and was on ventilator. This is post-weaning the patient on ventilator. Right. So this is what was started for her. And you see, after some time, she was out of ICU. Right. So this is the journey. It's still there, right? It's still to come up. What do we need? We need, I told you, in America they say lack of physician orders, 10%, 90%, 10% logistics. I think we are more on the logistic part, because we need logistics, we need more time, and we need to care for those who care for the patients. Mobilization is a toll, is a physical toll on the caregiver itself that we need to understand, and I think that is a great obstacle in the path of mobilization. What about our nurses and therapists, their backs are involved in caring for the patient, their backs are involved in mobilizing of the patients. So we need more time, we need more logistic support, we need the safety of the rehabilitation caregivers, and probably that is why we need equipments, and more importantly, we need, yes, everybody learns is complete, we need more number of attendees, more number of scientific data, right? So it's increasing day by day, I told you. So the lecture has an impact, right? And of course, I understand there is cost involved in it, whatever we say, and that is another logistic obstacle, right? But again, to tell you, if we consider the value of a treatment, see, if we equate value, it will be outcome divided by the cost, right? So if we can increase the outcome, the value increases, even if the cost increases a little bit. That is what I have projected here, right? So the outcome needs to be improved, right, in that scenario. And if the outcome improves, we can justify the increased cost that comes with the rehabilitation. And you see what wonders it has done. To come here where life starts, we really need to contribute for ourselves, right? So this is, I think that the aim of the treatment is to make the person in their baseline, right? It doesn't stop with noradrenaline, it doesn't stop with IVIG, it doesn't stop with weaning the person a ventilator. This is another case. You see, he had a road traffic accident with a polytrauma, presented with a quadriplegia, and he had a C-spine fracture. Actually, it was probably not it was a road traffic accident. He fell on the road. It's not a road traffic accident. He was carrying, he's a farmer. He was carrying the sacks of rice on his head. And while carrying it, the sack of rice is tipped off. So that was the mechanism of injury. And he had a C-spine fracture. The spinal fixation was done. And again, I couldn't take the photos of the patient when he was on a ventilator, but you can see he's tracheostomized. And we kind of managed to keep him on an invasive BiPAP support, and he was completely quadriparetic. And how wonderful it is to see this man standing up when he came to the OPD to finally say, "Madam, yes, I'm there working in front of your eyes." So what matters the most to me, if we can think over it, what matters to us the most, the life in years or the years in life? Thank you. So I'm open to the questions.
Thank you. I will invite next speaker, Dr. Gaurav Shyamashis, Consultant Physiatrist, Manipal Hospital, Mukundapur.
Okay, thank you, the chairperson. And thank you, ma'am, for giving the introduction of rehab at Neuro ICU. So I work in Manipal Hospitals, Mukundapur branch. So we know that ICU rehab, it's a multidisciplinary approach just to overcome the physical, cognitive and the psychological impairments of the patients. So it goes beyond the ICU. The impact of ICU admission already ma'am told, starting from the, like all the systems are affected. Mostly we see the MSK functions. Like there is a critical illness neuropathy, myopathy, polyneuropathy. There will be a joint contractures. Because of the prolonged bed-bound state, it can cause osteoporosis, joint contracture and all. So see this patient, he was in the ICU, later recovered. Now look at his ankle. It is gone into like in the ankle in equinus. So if it was properly taken care of during the ICU stay, probably wouldn't have landed up in this position. So even in the cardiovascular system, again the resting heart rate may go up because of the prolonged bed-bound status. There is increased of deep vein thrombosis, and the delayed complication is pulmonary embolism. And when the patients try to get up from the bed or during the mobilization, there is a complications of orthostatic intolerance. See this patient, she was on ventilator. She's a patient with myasthenia crisis. She was on, just put on tracheostomized. She is cognitively alert. But see, look at the X-ray. The left lung, it was collapsed on the left side. Just the atelectasis, because we see that if the patient is on ventilator at least only for 24 hours, that leads to diaphragmatic weakness and diaphragmatic atrophy, and landed up into VAP and atelectasis. We get lot of referrals from the neuro ICU classically when the patient is in disorder of consciousness. Most commonly after traumatic brain injury, or a lot of patients with a delirium, cognitive issues. The primary things what should be done is early mobilization and physical activity. There are a lot of evidence is also coming up, but the problem is what ma'am said, the logistics, because it needs lot of manpower. It needs proper assessment of the patients, when you can start mobilizing and at what time you have to stop the mobilization. See, first thing, the part of the early mobilization is the positioning of the patients. So this, look at the patient's ankle. The patient is prone to develop equinus in the ankle. At the same time, there will be a risk of ulcer at the heel. So just simple things, we used to keep like water-filled gloves just below the heel, just to prevent ulcer. Just keep a pillow in the ankle, just keep it in the neutral positions. These are the most common site of ulcer we know. These are the simple equipments which should be kept in the ICU, and the proper positioning. So you see the towel, just simple towel which is kept in the, just help to open the hands. Otherwise they will land up into clenched fist and the contracture. Even the positioning of the shoulder, like we see most of the shoulder, like stroke patients, they'll end up with a hemiplegic shoulder pain. So if we take care of the shoulder, keep it abducted, just prevent the pectoralis contracture, the adducted, then that will prevent the next up, when the patient will get better, his shoulder will not be subluxed. And another mobilization is gradually when you start the patient rolling in the bed, go for the long sitting in the bed, and then the high sitting. High sitting means just make him sit in the chair. And then gradually you can tilt the patient on a tiltable, and later on with the hoist you can mobilize the patient. This is the picture right side, where earlier I was working in INK there. Cardiorespiratory is very important part. Most of the patients who is on a mechanical ventilation, simply we see the prescription like chest physiotherapy. But what is chest physiotherapy? First we need to assess the patient. What type of injury? What is the patient's clinical status like GCS, CT findings? What is the patient intracranial pressures? If the patient is on ventilation, what mode of ventilation is on? Whether it's a mandatory ventilations or patient is on spontaneous mode. Patient's hemodynamic status, patient sedation level. You can assess the RASS for the delirium. And at the same time, you have to see the associated injuries. Most of the patients with brain injury, they might have the spine injury, rib fracture. You have to be very careful before starting chest physiotherapy about those patients. The intervention like positionings. airway clearance techniques. There are something called manual techniques. Simple, we do all like percussion, vibrations, suctioning of the ET tube and the tracheostomy, and assisted cough like abdominal or costopenic thirst during the time of expiration that can mobilize the sputum. Lung expansion and lung recruitment, these are the difficult techniques, but you can teach the patient when they are becoming a little bit of alert, mostly diaphragmatic breathing or the incentive spirometry. Inspiratory muscle training when the patient is on ventilator. Patient is on ventilator, so diaphragm is not working, they are at risk of atelectasis. So if the patient is on ventilator, you just see the patient pressure support, and you can reduce, along with the consultation of the intensivist, the pressure support. You can just for 5 minutes you can reduce. If it is 12, just make it 10, and if the patient is alert, you just see whether the patient is taking some breath. So that's why you can just trigger the diaphragm. Diaphragm has to work. But make sure the patient is on not distress. So you can give in between, like every day 5 minutes of, you can reduce the pressure support and train the inspiratory muscles. High cervical spinal cord, this again complication, like most of the patients, it is very difficult to wean off from the ventilator. So for this patients, we just teach them the manual breath taking with resuscitation bag. So with the closed resuscitation bag, like ambu bag, we have to just keep squeezing the bag to increase the inspiratory volume. And the glossopharyngeal breathing, that is very difficult again for the patients, but in chronic spinal cord injury, you can teach them. Ventilation weaning also is important. Part being a rehab physician, you have to see. So firstly, you have to see whether the patient's, what is the acute phase of the disease that is resolved. Patient has adequate cough. Patient can manage his secretions and the hemodynamic stability. And this chart we follow actually the daily screening for the respiratory functions. And you see that patient is on continuous mandatory ventilation, so gradually progress to SPONT or CPAP mode, and then TP trial followed by extubation. But what we have to know that pre-extubation, you have to just find out what is the particular best time to extubate the patient. That's why positioning, good chest physio, and the lung volume recruitment. So you have to make sure that all the lung segments are properly ventilated. You have to teach the patient assisted cough and the suctioning. And as soon as the patient is extubated, now you have to teach the patient diaphragmatic breathing, use the incentive spirometer. You have to calm the patients, and ongoing clearance and early mobilization. Post-extubation, you have to keep on doing that so that prevent the NIVUs also. Tracheostomy, again, sometimes lot of subacute patients, we take them patients in the rehab ward who is on tracheostomy. So some tracheostomy, like proper things are humidifications. These are the various methods you can use. Mostly the common is the saline nebulization. Suctioning. In private hospital, we see like closed suction in most of the areas. These are the things like how frequently you do suctioning. If there is a clinically, you will see there is a like patients, there is a like strikes or reasonable practical balance. How far you have to do suctioning and what should be the pressure. Stomach care, cough management. So tracheostomy, usually we see the tracheostomy with cough, but when the patient is gradually weaned up, because the cough prevents any kind of aspiration, but you have to see the cough pressure every day. While reinserting the tube, this kind of complication may happen, like a false passage. We have seen last 1 week before, one patient just we advised like change of tracheostomy tube in the same size, but it was gone into false passage. Ultimately, patient had to put back into the ventilator, again 2 more days of ventilator stay. Now, decannulation is also step-by-step process. You have to keep the cuff deflated and gradually wait for 24 to 48 hours in deflated position. If the patient can speak, we put the speaking valve and then cap up or block the tracheostomy tube. If the patient can tolerate for 2 days, then we can successfully decannulate. And if the decannulation is failed or the patient is not able to tolerate blocking, then you can go for the fees to see any kind of subglottic stenosis or any kind of granulation tissues. Some predictors of successful decannulations in patient with tracheostomy patient, like if the patients with high neurological status, if the GCS is better or the CRS is low, then definitely patients can be deextubated. Lesion localization, if the brainstem is damaged, then patient will take long time. Type of lesions, traumatic has better prognosis. If the patient has a good cough, good swallowing, there's no tracheal lesions, there's no pulmonary infection, then it is easy to extubate the patients. Swallowing is an again important factor. Even 24 hours after extubation, we should assess swallowing. See the patient's alertness level, any kind of dysarthria. If the patient has a drooling, what is the uvula movement, cough strength, gag reflex. This is a simple GUSS ICU score that you can ask the sisters to follow. Delirium, again, very common complications. We can see some scores like CAM ICU we do, confusion assessment method in the ICU. And the treatment is same, early mobilize the patient, because most of the closed ICU it is very difficult to see the sunlight also. And sensory optimization, if the patient has any glass, if the patient has a hearing aid, just ask the relatives to bring it. This is kind of, if the patient is delirious, don't do the left-sided one, like they have tied both the hands. Should avoid. Ideally, patient should be kept in the right-sided picture. It's again a big topic, disorder of consciousness. Like if I have time, I'll just see that the patients who has a severe traumatic brain injury, first they will have the coma, that is a no eye opening. Then it will go to UWS, an unresponsive wakefulness state, or previously it was called vegetative state. Only eye opening is there. Then minimally conscious state, when the patient has a speech minus or plus based on the speech. And then emergence from the minimally conscious. Emergence means when the patient knows functional use of the object. You give the patient a comb, patient started combing with hair. So that means patient has emerged from the minimally conscious. This patient with a pontine hemorrhage, see patient came with a locked in state, so with a preserved vertical eye movement. So it should not be confused between the vegetative state and the locked in state. This is one important point I thought the ACRM and ANN guideline 2018 that never say universal poor prognosis in the first 28 days post-injury. This is a level A recommendation. Whatever be the patient's clinical status, whatever be the scans. And track TBI study showed that patient progressing to minimally conscious state within 5 months of injury, they generally have better long-term prognosis compared to vegetative state. So minimally conscious state within 5 months, they have a better prognosis. Coma stimulation, there are various methods like a sensory stimulation. Along with that, some advanced techniques also can be done to awaken the patients from the vegetative state or minimally conscious state. Coma stimulation kit we used to have at INK. These are the various, like all the peripheral senses you can stimulate, starting from the tactile, music, vestibular. This is an important study I found that live music in the ICU. So this probably helps the patients to be more comfortable. All this, now the concept of silent ICU is also coming. So live music also, that can be also experimented. This is again we used at INK that median nerve stimulation. So median nerve, the path, like you are stimulating the peripheral pathway, and the central you are stimulating basically the sensory part of the brain. So this kind of 20 milliseconds or 40 milliseconds on you can use. You can change it based on your center. A new concept is coming, vagal nerve stimulation. There's a lot of use now, starting from the epilepsy to to calm the patient in anxiety to disorder of consciousness. Hyperbaric oxygen therapy, it's a like adjunctive treatment. It has been shown that hyperbaric oxygen therapy, the patients who have received HBOT, they have better prognosis than those who haven't. So to conclude that ICU rehab starts at the bedside and not after the ICU discharge. First you have to take the precautions. You have to see how many lines patient has. If the patient has EVD, just block the EVD and then mobilize. You just count how many lines, like the central line to the Riles tube, all this you have to count. So you need one person specifically to count the lines. And someone has to hold the patient. If you have a hoist, then it is good. So you need a lot of manpower, a lot of logistics. Use clear inclusions, like when to mobilize, there should be a criteria, and when not to, and when you have to abort the mobilization. Watch for neurological red flags. So there is a risk of change of GCS or drop in GCS, in new focal seizure, pupillary changes. To always the cardiorespiratory stability you have to assess. And it is multidisciplinary teamwork. Ultimately, you have to work in liaison with all the departments. Thank you.
Thank you, Dr. Gaurav. Excellent presentation. Very interesting too. I have one question. I am not from rehab background. Okay. So a patient, critically ill patient admitted in ITU. So, what are the main domains? Say 4 or 5 domains where this rehab intervention is mandatory. It has to be done. Is there something like that?
So primary things, most of the patient, if the patient is on ventilator, first is the look chest. Because atelectasis very common, diaphragmatic weakness, so chest. Ultimately what happens, you have to prevent the VAP. I don't know how much it will be successful, but VAP is a very common, so mostly in the like semi-conscious patients, it depends on what is it. If the patient has cervical cord injury or GBS, what it will do. First we have to look after the chest. That is the primary, and then the muscle.
Mainly to prevent VAP.
Mainly to prevent VAP and early weaning also. Yes, ma'am.
Rheumatologist.
Okay, sir, I would, from an intensivist perspective, right, I would like to mention there are 4 or 5 domains where I will mention the contraindications. Apart from that, all patients in ICU need rehab, sir.
Yeah, that is the question I was going to ask you.
Yeah.
When you defer to calling rehab?
Yeah, we defer to calling rehab where I see Gaurav has mentioned that if there is a rise in intracranial pressure, which we think rehab can cause a further surge in ICPs, we do not do it. For all cardiovascular instabilities, the patient is in really is in hypotension and increasing vasopressor support, probably no. If we see that rehab is increasing the cardiogenic shock or the heart rate to the extent where it can harm the patient, and spinal injuries if they are not fixed in, right? So those are the 4 or 5 major contraindications that we see for rehab. Otherwise,
debatable question, but I would like to answer regarding the domain. Actually, what is happening to the patient? Patient is lying on the bed, totally immobilized, with support or without support. Support may be of this spectrum. So our main domain is mainly concerning what is happening, this cardiac deconditioning, pulmonary deconditioning, or musculoskeletal deconditioning. From rehab perspective, these 3 things we can take care of without harming the patient. And depending on what kind of conditioning exercises we are planning to do, and what kind of preventive this exercises we are planning to do, or therapeutic exercises. Again, regarding this increase in the rate of this heart rate, if you follow the assistive active exercises, passive range of exercises, stretching exercises, this chest decongestive therapy, it is not going to harm the patient in any way, but rather it will help the patient in gaining the conditioning after the patient will come out of this acute support. So these are the things actually, I am just as you have asked regarding the domain, these are the 3 domain and area of concern for us. But it depends on case to case and vary as per the assessment of the patient. And rehab at any time, it's not going to harm in any way if it is done in a supervised manner by an expert clinician, not under the person who has no knowledge about what is going on with the patient. That is my take.
Shyamashis, just one more addition to this. Gaurav's thing, he has presented very well. Just one comment on this. In terms of rehab, whatever Dr. Pandey and Gaurav has mentioned regarding exercises and part, but one thing which we really need to keep in mind, in the neuro setup, we will have patients who are still in the comatose stage. So one important part is we need to start a patient on coma stimulation program as early as possible. So that is also something which we really need to keep in mind, besides the exercise part, which is an integral part of rehab.
Thank you.
Thank you.
So, thank you. If there is no further question, we will conclude the session.